Hi, I'm Dr. Jennifer V. Brown, your stroke specialist, and I'm aging gracefully with the stroke diagnosis due to sickle cell disease. And today we're going to discuss four-sided hip movements to improve the stance phase of gait. So, what you really need to do is load the hemiplegic leg first. We're always taught that you should move it first with step initiation, but I work on stance phase control first. And the four movements that I do with the less affected extremity are hip flexion, hip abduction, hip extension, and hip adduction. I find that hip adduction is the hardest because I really want them to cross midline and control that femoral pelvic movement on the hemiplegic leg. But they often can't do that. So I look at controlled movement back to midline after abduction. So in the first picture here, this gentleman, he has his hemi walker that he brought to clinic with him. And I said, you can hold on to it. I have your hemiplegic leg. I'm going to hold it steady. I have my shoulder to facilitate hip extension. I'm giving an input through my hands at the distal femur down towards his ankle, not backwards to facilitate knee extension. And all I wanted him to do was take a step forward. And he had difficulty doing that. It was not until I put him in a standing frame so that he could get equal weight bearing and then put him on a platform walker to get equal weight bearing through his hemi arm and use of his less affected arm that he started to trust that hemiplegic leg and take a step forwards and backwards. In the two middle pictures, this is an example of hip abduction. I'm really using my shoulder right behind that greater trochanter to help stabilize that gluteus medius so the pelvis will not drop down as he abducts the other leg. I did not want him to hike the pelvis on that less affected side to abduct. And again, you see my pinky finger going down. That is to get input through the ankle, and I'm not pressing backwards with my fingers. I'm doing an internal rotation movement because this is closed chain because the femur internally rotates with knee extension to stabilize that leg. I'm not pushing backwards. And then on the next picture, I'm having him come back into adduction, which is midline. And he didn't trust his leg to bring it back. So you could tell that he bent a little bit more and he was resting on my shoulder. So that tells me in order to get this muscle to work, the adductors, I really needed to stabilize the hip internal, external rotators of that right hip, as well as that glute maximus and glute medius to help. And then in the last picture, I have this client facing her sink so she could hold on if there was a loss of balance. And I didn't want her to bend over. So I wanted to keep her lower trunk touching the sink surface facing her. And then I told her to step backwards with your less affected leg, not letting the knee bend on that hemi side. And so that input of the front of the sink, of her lower abdomen area being at the sink, helped to keep that knee straight as she took a step backwards with that less affected leg. So these are some clinical questions to ask. Is there a sensory or proprioceptive impairment? Can they even feel their leg? Do they have right-left discrimination that they're worried about shifting onto that leg to load it so that they can move the less affected leg? And is there adequate strength to achieve stance phase? We always tell people to tighten their knee, but at stance phase, the knee is relaxed 0 to 5 degrees of flexion. And what holds it stable besides the internal ligaments is the swing momentum of the opposite extremity. I try to make sure that glute maximus is turned on right after loading response to get the hip over the knee, and so that can be stable. And then you begin this progression of the hip and the knee moving in front of the ankle mid stance to terminal stance. Remember, I'm your trusted resource for all things stroke and ankle foot orthosis. Don't forget to check out my YouTube channel every Tuesday and Thursday. So subscribe, leave a comment, and share. And don't forget about the references. We have to use evidence based practice to optimize our treatment interventions to improve health outcomes. Thank you for listening to this video. I hope you learned a lot. Stay tuned for more. Bye bye.